Next, we'll be moving on to the second symposium for the day, another interesting chapter and an overview of a challenging concern in pregnancy, respiratory infections, an ongoing challenge in pregnancy. To moderate the section, let me kindly call upon Dr. Prabhat Randamage, the panel of experts, Dr. Daupadi Dharmasena, Dr. Amila Ratnapala, Dr. Geetal Pereira, and Dr. Upul Patirana to the stage.
Good morning. If we consider the last decade, we had influenza outbreak in 2015, and then 5 years down the line, we had COVID outbreak. So this is a very common topic that we encounter in our day-to-day practice, all the clinicians here. So welcome all of you for the second mini symposium of respiratory infections in pregnancy. We have 4 distinguished speakers. Let me introduce the first speaker, Dr. Daupadi Dharmasena. She is a consultant respiratory physician from DGH Trincomalee, and she will be discussing regarding the influenza and pregnancy. Over to you, Daupadi.
Thank you, Dr. Prabhat. And we'll move on to the presentation on influenza and pregnancy. So influenza is a member of the Orthomyxoviridae family of viruses, and influenza A and B cause seasonal epidemics, where C mainly causes mild respiratory illness. And depending on the H and N proteins, various subtypes of influenza A can appear. So influenza pandemics and emerging new pandemic threats exist since year 1900. So how can we clinically differentiate common cold and flu? So there are some clinical features more common in influenza than common cold. High fever lasting 3 to 4 days, headache, myalgia, fatigue and weakness, and extreme exhaustion, severe chest discomfort and cough. Where in common cold, the more common features are stuffy nose, sneezing, and mild to moderate cough. But high fevers, headache, aches and pains, and exhaustion are quite rare in common cold. So what is the global prevalence and impact? Influenza A and B viruses can cause seasonal influenza epidemics as well as out-of-season sporadic cases. Globally, about 5 to 10% of adults and 20 to 30% of children develop influenza A or B each year. And influenza-associated respiratory deaths are estimated to correspond to approximately 2% of all annual respiratory deaths. Studies have shown that influenza burden of disease is greater in low to middle income countries like us than in high income countries. And also, certain groups of people face high risk of serious influenza complications, hospitalization or death. Among these groups, the one we are going to talk in next few minutes, pregnant women at any stage of pregnancy and for up to 2 weeks after end of pregnancy are at high risk. And also children, elderly people, and people living in nursing homes and other long-term care facilities, healthcare workers, and obese patients, and people with certain high-risk chronic medical conditions like renal, liver diseases, and respiratory conditions like COPD, asthma, and diabetes, other neurological problems, and patients with people with weakened immune system due to disease like AIDS, leukemia, and immunocompromised due to medications like chemotherapy or long-term steroids. So we will talk about pregnant women and influenza. What are the factors affecting influenza infection in pregnancy? There are anatomical factors, physiological factors, and immunological factors. If we talk about anatomical factors, respiratory function is altered due to diaphragmatic elevation from the pregnant uterus and changes in chest wall dimensions and increased hormones, progesterone and beta-HCG, and physiological factors, increase in maternal oxygen consumption by 15 to 20% and lung tidal volumes by 30 to 40% and reduced residual volume as discussed in previous symposium. And immunological factors, suppressed cytotoxic T lymphocyte response and local and systemic immune system changes result in increased maternal susceptibility to severe infection from influenza virus, and also increased pulmonary inflammation due to cellular immune response cause increased morbidity and mortality in pregnant women. And studies have shown that pregnancy increases the risk of influenza-related hospitalization, as well as increased risk of serious adverse outcomes. And we'll see what are the maternal and fetal effects of influenza. Maternal complications are increased hospitalization, increased ICU admissions, higher influenza-related complications, and increased mortality, where the fetal complications are increased preterm birth, higher intrauterine fetal demise, and increased fetal distress. So in Sri Lanka, influenza has a significant contribution for maternal deaths in recent past years, about 10% of total maternal deaths in 2015 and 2016. What is the suspected case definition for a patient with influenza? The definition is a pregnant woman presenting with acute febrile illness with high fever, more than 38 degrees, with a spectrum of disease from influenza-like illness to pneumonia. And it is recommended that pregnant mothers should consult a qualified physician immediately if they have above symptoms, and the PHMs and field health officers should refer any pregnant mother with fever and flu-like symptoms for proper medical care without delay. So it is recommended for all pregnant mothers should be admitted to the hospital if they develop any signs or symptoms of progressive disease, or if they fail to improve within 72 hours of onset of symptoms, or is there any of these dangerous signs? Manifestations of cardiorespiratory distress by shortness of breath, either during physical activity or while resting, or the physical signs of dyspnea, tachypnea, hypoxia, or low blood pressure, and the radiological signs of pneumonia, and any features of central nervous system involvement like altered mental status, unconsciousness, drowsiness, seizures, confusion, and evidence of severe dehydration and persistent high fever and other symptoms beyond 3 days. And however, if they are even not very severe, a compulsory follow-up visit in 3 days' time should be arranged for each and every patient. So in hospital management, a consultant or the clinician of the highest rank should be informed and attended to the patient. And the prevention of spread during in-hospital stay is also important. So care for symptomatic patients should be organized in a separate area of the antenatal ward if possible. And all the preventive measures should be taken to spread infection in the ward. And antiviral therapy, this is important. All pregnant mothers with severe or complicated disease or signs of progression of the disease should be treated with antiviral drug, oseltamivir. And treatment with antiviral medication should begin without waiting for collecting specimens or laboratory confirmation. Chemoprophylaxis is not recommended during pregnancy. And oseltamivir is safe for use even in the first trimester. And treatment with oseltamivir to a lactating mother is not a contraindication for breastfeeding. And supportive care has to be provided, like adequate nutrition, rehydration, and medication, including antipyretics and antibiotics where indicated. And NSAIDs should be avoided for the patients with influenza and pregnant. And since there is high risk of fetal distress and preterm labor, sometimes we have to consider administration of steroids early for fetal lung maturation where applicable. And with regard to labor and newborn care, it is essential to provide routine intrapartum and postpartum care with attention to specific complications to childbirth and postpartum period. And the newborn baby should be assessed frequently to check whether the baby has got infection as well and has to support to continue breastfeeding. And the diagnosis, clinical specimens like throat swabs, nasopharyngeal swabs has to be sent to, has to be collected and sent to MRI, and it is available in the private sector as well. And if the patient has developed pneumonia, sometimes swabs may not be positive, so they might need bronchial or alveolar aspirates. And influenza-related maternal deaths need to notify always, and it should be emphasized that postmortem is mandatory to all maternal deaths from influenza-like illness. And how to protect pregnant women. So they have to be educated all the time if they develop any clinical symptoms of influenza to seek medical advice, and they should avoid unnecessary travel, crowded places, and they should be advised to stay at home and to practice good hand hygiene, and they should not provide care for flu-like patients, because they are prone to get infection, and the seasonal influenza vaccine can be given safely during all 3 trimesters of pregnancy. I would like to emphasize on vaccination, because the studies have shown that it reduces the risk of adverse influenza outcomes during pregnancy, and it reduces the risk of infant influenza, and it reduces the incidence of infant influenza-associated illnesses, and reduce incidence of preterm birth and infant mortality. So most of the organizations, including WHO, now recommend seasonal influenza vaccination to all pregnant women as a highest priority. And a recent study done in Sri Lanka, the influenza vaccination implementation in Sri Lanka, a cost-effective analysis, it showed providing influenza vaccine was considered highly cost-effective compared to no vaccines. So in summary, influenza more likely to cause severe illness in pregnant women, and changes during pregnancy make pregnant women more prone to get severe illness from influenza. All severe and complicated cases need antiviral therapy, and vaccination during pregnancy has been shown to protect both mother and her infant up to 6 months. Influenza vaccine can be given to pregnant women in any trimester, and postpartum women, even if they are breastfeeding, can receive flu vaccine. Thank you.
Thank you, Dr. Dawapudi, for that interesting lecture. And we will take up the questions at the end of all 4 lectures. Let me introduce our second speaker, who's Dr. Amila Ratnapara, consultant respiratory physician from National Hospital Galle, and he will be discussing about COVID-19 and pregnancy. Over to you.
Hi, good morning. First of all, thank you so much for the invitation for the both of the colleges. So I'll be discussing COVID-19 management based on a case which I managed in Kandy in the latter part of 2021. So it's a success story anyway. I mean, it's a 34-year-old previously healthy lady presented with cough and fever for 3 days duration in her 35th week of gestation. And she's unvaccinated, and we found that she's positive for COVID-19. And then we had an immediate discussion with the obstetrician had a discussion with us at MDT, and we decided that this patient should undergo emergency LSCS because that she has evidence of distress, that's maternal tachycardia, but she's not hypoxic, she's slightly tachypneic. And the obstetrician have actually at that time went ahead with the emergency LSCS. So if you think this lady, it is latter part of 2021 where the vaccine program has been introduced to Sri Lanka. What is the place for COVID vaccine in pregnancy? So if you go for the risk factors, you can see here the age is the main risk factor. When the age is advancing, the risk is going more. So for example, if the age is more than 85, the relative risk is about 10. If you consider diabetes, hypertension and all, the relative risk is about 1.3, 1.5. But if you consider pregnancy, the adjusted relative risk is about 3.59. So it is more than the diabetes and hypertension. So it comes to the category of where about age is around 50 to 60. So it's a high risk category where the vaccine is indicated in all pregnant women. So this patient should have been vaccinated, ideally. So this is a TESI database from Europe, where they collect all the data of patients with COVID. As you can see here, patient who had the vaccine, as you can see here, had the vaccine, had low prevalence of admissions compared to the patients who didn't have the vaccine. So it's clearly it's seasonal. You can see more in the early years as well as in the late years. But as you can see here, that the vaccination prevents hospital admission. So there's no doubt there's indication for vaccination. So what are the facts versus myths of COVID vaccination? Well, the vaccination for COVID in pregnancy is strongly recommended, and it's a priority group. Unfortunately, we don't have the vaccine at the moment because of the many myths that associate with the COVID vaccine. The vaccine can be given at any trimester during any stage of pregnancy, preconception, during the pregnancy, first, second, third trimester, or during the postpartum. So there's no issue. And we have long set of data, about 35,000 patients involved in this post surveys, vaccination surveys. It is absolutely safe. But we are mainly talking about the mRNA-based vaccines, the Moderna and the Pfizer. And the vaccine-induced thrombosis and thrombocytopenia, which is the main concern for everybody, if you ask from in Sri Lanka, that they are worried about thrombotic risk factor. But it is extremely rare, 1 in a million cases, and it is more common as with the Oxford AstraZeneca vaccine, which has been discontinued by the companies now. And vaccine does not affect the fertility. So therefore, you can take the vaccine during the preconception. So there are a lot of myths, and you have to address these myths of the patients. Well, what is the place for antivirals in this lady? I mean, this patient has evidence of early disease, day 3 of the illness. Whether we could have given antivirals? Answer. Most of the antivirals, that is Paxlovid as well as the molnupiravir, oral antivirals, they are teratogenic. So we do not recommend oral antivirals for these patients. However, remdesivir, which is the IV form, which can be given in exceptional situations, but still the FDA advises that the effect should be more than the side effects, so the toxicity to the fetus. So they are fetotoxic, but still we should be dealing with the situation where we are going to save the lives of patients. But again, the remdesivir is not a, I mean, it's a good drug, but again, the relative risk reduction of hospital admission or reduction in the severity is not that significant compared to the Paxlovid as well as the molnupiravir. Anyway, the oral antivirals are contraindicated. The intravenous one we might use in certain situations. So what is the place for monoclonal antibodies for this lady at the early stage of the COVID-19 illness? Again, we have two options, the sotorimab as well as the casirivimab and the imavimab, which are not available in Sri Lanka, but they are absolutely marvelous medications. In the community setting, if the patients are at high risk, I have personal experience with sotorimab, the relative risk reduction is 0.12 for mortality reduction. For example, if the patient received the sotorimab, the death of that patient due to COVID is reduced by 88%. And the hospital admission is prevented by 45 to 55%. And it is same with the casirivimab and the imavimab. They are amazing drugs. We are very frequently using in other countries when the oral antivirals are contraindicated or which we can't use, but they are really effective. Unfortunately, we don't have neither of them. Right, and then if you come to the case, the patient became hypoxic immediately after the section, but the fetus was all right, and then she was transferred to the ITU. You can see that the chest X-ray of the patient on admission, there are some peripheral shadows, as you can see here. But if you come to date 1 of the admission to the ICU, that all 3 zones of the lungs are involved. So it's a rapidly progressing disease. When you come to COVID, we know there are 3 stages. The viremic stage, that there's a initial, the patient coming with fever, and the patient was in stage 2, where the pulmonary stage, even though the patient was not hypoxic, there's involvement of the pulmonary infiltrates, but now patient is going into the hyperinflammatory phase, which is the most significant phase where the patients would die. Why it is important to identify the hyperinflammatory phase? As you can see in this graph here, the patients with hyperinflammatory phase, that the probability of escalation-free survival drastically goes down compared to the patients who do not have the hyperinflammatory phase. There are many definitions for hyperinflammation, but what happens in hyperinflammation is that they will develop increased CRP response, high ferritin levels because of macrophage activation and IL-6 activation. So what is the place of steroids in this lady? We started steroids because of the recovery trial, as you can see here. I'd like to stress the fact that the patient is hypoxia or ventilate support, the steroids are beneficial. But if the patient is not hypoxic, as you can see here, that they are lethal. So if the patients are not hypoxic, just COVID viremia or any other viral infections, don't use steroids, they are lethal. That increase the mortality. Right, what is the place for IL-6 treatment? Again, tocilizumab, we have meta-analysis, many studies. I mean, if you select the patient correctly at the early hyperinflammatory phase, there's a benefit. And mortality benefit, but not in all cases, especially if there's bacterial sepsis, it is absolutely contraindicated, which increases the mortality. What is the place for anticoagulation in this patient? For our lady, we started on tocilizumab as well as with IV dexamethasone. What is anticoagulation? Again, we have many studies. As you know, COVID increases the coagulopathy. It causes endothelial dysfunction, therefore microthrombosis. As you can see in this study, the patients who received either therapeutic or prophylactic dose of anticoagulation have mortality benefit compared to the placebo. However, due to the safety concerns, we are using we are using actually a prophylactic dose of low molecular heparin as our first line option. You can use unfractionated as well, but there are many trials going on at the moment to see whether there's any benefit over DOAC versus low molecular heparin. If I summarize, in COVID, not only in COVID, most of the illness, influenza, bacterial infections, they have an early viremic phase, and then they will proceed into hyperinflammatory phase. And we have a very limited window of opportunity where we should intervene there. And if we don't intervene at this indolent period of the early hyperinflammatory phase, patient will progress, and this is the point of no return. You might do everything at this point, and patient will die, irrespective of all the interventions. So, identify the correct patient, have MDT approach, and then intervene early in COVID-19 to prevent mortality. Thank you so much. And I'd like to answer if there are any questions at the end of the session.
Thank you very much, Shamila, for being strict to the time. So we'll move on to the third speaker, Dr. Geethal Pereira. He's consultant pulmonologist from Sri Jayawardenepura General Hospital, and he will be discussing about bacterial pneumonia and pregnancy. Over to you, Geethal.
Thank you. Yeah, good morning. This is going to be a fairly simple thing. We will try to do it soon because it's eating into the tea time, isn't it? See a few familiar faces, lots of them not so familiar. So we discussed about viral infections, the COVID. Now we move on to bacterial stuff. This is what you see in clinical practice also. I'm sure most of you are clinicians. Right, okay, I choose to skip the case. Oops. So we are talking about pneumonia, which is a specific condition. By definition, you are talking about a disease with X-ray infiltrates. So if you are diagnosing pneumonia without an X-ray, having X-ray and supporting your diagnosis, sometimes if things go wrong, you will have to justify why you diagnosed pneumonia without X-ray. So, and then you have different types of pneumonias. Of course, bacterial pneumonia is what I'm going to talk about. You have viral pneumonias, fungal pneumonias, and this is ICD classification, and pneumonias of organisms not known. And also the pneumonia depends on, you will see why this is important, because it's all about treatment. How do you choose a treatment? So you have pneumonias that are acquired in the community. And then you have things that are nosocomial, hospital acquired, ventilator associated. There are different names. because what is important here is the organisms that involve are different. So the way that you choose your antibiotics is different. And then you have this classification also of typical bacterial infections, atypical pneumonias, and then aspiration pneumonia, which is very important for respiratory patients, and chemical pneumonitis, which may not be involving a pathogen, and then viral and fungals. Okay, now we are going to focus on pneumonia in pregnancy, not on pneumonia as a whole. Now, how frequently does it happen? Now, it all depends on how you look at it. And if you look at all the studies from all over the world, this is what happens when you read the literature. Different people come up with their experiences depending on those environments. So, depending on how you look at it, it's some areas pneumonia is very high among pregnant people. Some areas it's not. And I suppose it depends on how much of X-rays you take also, because if you don't take X-rays, then you don't diagnose the pneumonia, and that's also easy. So you don't have any pneumonias in your practice. Historically, we tend to think that pneumonias are bad in pregnant people. I mean, if somebody gets pneumonia when you're pregnant, you're likely to die. That's what the historical thinking is. But when you look at the newer studies, it's not that bad in pregnant compared to the normal population. Don't ask me for the reasons. Probably the pregnant people get better care compared to a non-pregnant 27-year-old girl who gets a pneumonia. A 27-year-old pregnant girl will get better care, and she's less likely to die. So that could be one reason, but if you look after them well, they will not carry an additional risk. So you don't have to panic if you are looking after your patients, basically. So what? Now, coexisting maternal diseases increase the risk of contracting pneumonia in pregnancy. Now, your patients, the VOGs, your patients are getting older. Age is not an issue, but they have coexisting diseases also, so you are more likely to be dealing with pneumonias if they come with respiratory tract infections. And then you have the neonatal effects, especially low birth weights and increased risk of preterm birth. So if you don't look after these pneumonias properly, you're going to have a lot of neonatal issues. You need to be good with your neonatologist, because otherwise there will be a problem managing the whole case. And of course, the maternal complications, we are all worried about going for that conference. We don't want to go there, and because they can have respiratory failure and some of them can die. And that's one reason why I think we have these things, because we don't like the maternal mortality conferences. The pathogenesis, there are two ways of looking at it. I presented these slides before also. The traditional thinking is that you get a bacteria from somewhere and then it goes into you, and then it causes a pneumonia, either by aspiration or by inhaling something. So it depends on the virulence of the bacteria and all that. And then we find I missed the other slide. Then we have got to know about the microbiome, where we know that the respiratory system is not absolutely sterile. So you have bacteria living in there, and then they can cause pneumonias, infections, if your host is not that strong, or if there are factors that change the balance. The clinical features are more or less the same. I won't go into this because all clinicians, you all meet these people with coughs and colds and dyspnea and pleuritic chest pains, and all conditions are like that. As for the physical examination also, all these things are in the books, but one thing I want to stress is tachypnea is not normal in pregnant people. In pregnant people, the respiratory rate is essentially normal. They may be dyspneic, but tachypnea is not normal. So if your patient is tachypneic, look a little carefully. Then the big thing about investigations. Yeah, it's interesting that how we look at this X-ray thing. You know, the discussion also shows the pathology behind all these things. Whether it's a pathology or the right thing, I'm not judging. Yeah, nobody wants to do X-rays because you will be blamed for the autism they get to whatever. So why not use the ultrasound now? Yes, you need some training, but you guys have ultrasound. The VOGs have ultrasounds in your wards. And when you say that this patient is having chest pain and you have to have a respiratory person to come and see, of course your MO can, or somebody can just have a look, The ultrasound is there and you can have a look. And you might see things and learn. Then about the bacteriological diagnosis. Now, all of us know that the cultures take time and you can't wait for the cultures to zoom in on antibiotics. So the way the world is moving is nucleic acid amplification tests. There are these panels now in the world coming up, so instantly you can diagnose your MRSAs and things like that. So they're useful, and hopefully we will have them once economic crisis settles. So ultimately, if you want to make a diagnosis, you better have a infiltrate in your chest imaging. Then coming to the risk factors for pneumonia, and anemia is very well documented, and they talk about asthma. Now, if you have a history of asthma, your chance of getting your patient is chance of getting a pneumonia in pregnancy is high. So, do we screen for them and treat them when they get pregnant? Question to answer. And then, of course, if you use tocolytic agents during the labor or antepartum corticosteroids, the risk is apparently higher. So in patients we use these things. Maybe those are complicated patients also. You have to look at the possibility of pneumonia if they develop fever and things like that. Of course, the other things are obvious. The pathogens. Now, the pathogens are more or less similar to the other population when it comes to the community-acquired pneumonia. But few things I want to just stress on. Strep pneumonia can be resistant because resistance is coming up because of antibiotic usage. So so you got to look at the possibility of that if somebody is not responding to the normal dose of antibiotics. And especially for people, this is what is there in the literature, for people who have contact with children in daycares, because they have a lot of cross infections. So just think about it, and you may need higher doses of antibiotics, beta-lactams. And then community-acquired MRSA, especially after these influenzas, community-acquired MRA is a real thing. And they may not respond. Staph is a nasty organism, so you may have to use things like teicoplanin. Pseudomonas in these bronchiectatic patients, you better treat, if you know that your patient has a history of structural lung disease, Pseudomonas, the antibiotics are different. The typical cap is that and then the aspiration pneumonia, which is supposed to be common because of these factors: increased intragastric pressure, relaxed esophageal this thing, and then we use sedation, analgesia, and then also you basically press their tummies too hard, and then they probably aspirate due to you pushing their tummy too hard. Don't do that. The atypical pneumonias are a different group of organisms that needs macrolides to treat. So you can't diagnose these things offhand. So you got to suspect if your white counts are not very high. There are investigations that you can do, but you got to do. So I'll rush into the take-home messages. Bacterial pneumonia in pregnancy is a possibility, especially in the second and third trimesters. Aspiration pneumonia is very common during that time. And asthma in pregnancy is associated, it's documented, so look out for asthma. Organisms are similar. Tachypnea is abnormal, and you need to look at imaging in whatever way you want, whether you want to do x-rays or ultrasounds or both, it helps. Thank you.
Thank you, Dr. Geeta. So let me introduce our next speaker, Dr. Upul Patirana. He is consultant respiratory physician and honorable joint secretary of SLCP. And he is from Base Hospital and District Chest Clinic of Puttalam. And he will be discussing about tuberculosis and pregnancy. Over to you.
Thank you very much, Prabhat. Good morning to everyone. Right. So, tuberculosis caused by the organism Mycobacterium tuberculosis. And the exact incidence of Mycobacterium tuberculosis caused by MTB in pregnancy worldwide is not known. But WHO estimate it's around 200,000 per year. And it is associated with adverse maternal and fetal outcome. So therefore, this is a topic to discuss and we should well manage. In the past, historically, the physicians thought that tuberculosis never cure. And if you develop tuberculosis, you die. And also tuberculosis in pregnancy in Hippocratic era also thought the pregnancy is protective of tuberculosis. Why? The gravid uterus push the diaphragm up and lung collapse. So therefore the lung cavity collapse. It cure the problem. Therefore at that era, unmarried women with tuberculosis was advised to get pregnant, marry and get pregnant. But later realized this increased the mortality. Therefore the recommendation was to terminate all the patients with tuberculosis and pregnancy. Finally, so with the advancement of medicine, so there are effective medications for tuberculosis and antenatal care, obstetric care has improved. So therefore good outcome with tuberculosis and pregnancy. Therefore we should keep our hands together to improve the outcome further. So our team wanted me to discuss tuberculosis in pregnancy in 10 minutes with the case history. This patient actually I recently saw, a 31-year-old pregnant lady. She was found to be HIV positive during her routine screening and then referred to me by the venerologist. Why? To screen for tuberculosis. Should I? Yes. Why? Pregnancy is a risk factor for tuberculosis and also pregnant patient with HIV increase further risk of tuberculosis. Therefore, I started screening. How should I screen this mother for tuberculosis? The symptoms of tuberculosis in pregnancy is not different to other patients. And so therefore, the WHO recommends 4 symptom screening method: cough, night sweats, fever and weight loss. Here actually regarding the weight loss, we should be very careful. In normal patients, we can expect weight loss share. But in pregnant patients, it may not be the true story, but maybe not gaining the proper weight as expected in pregnancy. And this patient actually I saw some times ago, she was on treatment for cough as for bronchial asthma. And when we see the chart, weight chart, there was absolute weight loss and found to be sputum positive and chest X-ray also consistent with tuberculosis. And then the physical examination to look for evidence of pulmonary tuberculosis. And also we should keep in mind that these pregnant patients are also at risk of developing extrapulmonary tuberculosis. And 5 to 10% of patients with tuberculosis and pregnancy develop disseminated tuberculosis as well. So which is one of the risk factors to develop congenital tuberculosis as well. Right, so this lady had bilateral cervical lymphadenopathies and respiratory system examination was normal. And what diagnostic tests are indicated in this lady to diagnose tuberculosis or to rule out? So as in any other patient, sputum microscopy to look for acid-pass bacilli and also the novel technique like gene expert, more sensitive, and also sputum culture for Mycobacterium tuberculosis. So we have discussed enough regarding the chest X-ray. So there is no contraindication. We went ahead with chest X-ray as well. And also because of lymphadenopathy, again the commonest cause of EPTB, TB lymphadenitis, we went ahead with ultrasound scan of the neck. And we should consider FNAC or biopsy of lymph node for histology and microbiological testing. Her sputum microscopic testing and gene expert were negative, and Mycobacterium tuberculosis culture will take some time. The chest X-ray was normal. Ultrasound scan confirmed cervical adenopathy, but with preserved hilum preserved fatty hilum suggesting reactive nodes. So therefore, we went ahead with just only FNAC without putting the patient for general anesthesia and biopsy, which confirmed reactive nodes. So therefore, in conclusion, she is asymptomatic with regard to respiration, and chest X-ray was normal, sputum microscopy normal, the lymph node FNAC reactive, we concluded patient does not have tuberculous disease or tuberculosis. Right, then the next question is the popular testing, Mantoux test. Is it indicated in this patient? So in accordance with WHO guidelines, the tuberculin skin test, Mantoux, or interferon gamma release assay. These tests can be offered to diagnose tuberculous infection, not to diagnose active disease. So when we do Mantoux test, when we read the Mantoux test, we should read the induration, diameter of the induration, not just the redness. So you should learn that one also. So she underwent Mantoux test, which read 12 millimeter. Usually, when it is more than 10 millimeter, it is positive. In HIV patient, even more than 5 millimeter, we take it as positive. So therefore, the final diagnosis in this lady, it is latent tuberculous infection. So what is this difference? Latent tuberculous infection and tuberculous disease or tuberculosis. Tuberculosis develop in 2 stages. So the first stage occurs when the tubercle bacilli enter the body of an individual but remain dormant without causing the disease. This is tuberculous infection. The second stage initially might be preclinical without any symptoms. They start developing the disease, finally end up with full-blown tuberculosis. Right. So, do you offer treatment for latent tuberculous infection, and if it is any difference from tuberculous disease? Yes, this is in keeping with WHO guidelines and also adopted guidelines, national guidelines. We should treat latent tuberculous infection. Not all patients, and HIV patients, it is absolutely indicated we should treat because there is a high risk of reactivation. So this is different to treatment of tuberculosis, where tuberculosis you treat with the full course of treatment, 4 drugs combination initially for 2 months, then 2 drug combination 4 months. So LTBI treatment, you can offer isoniazid treatment for 6 months or isoniazid rifampicin combination for 3 months. Right. Are these anti-TB medications safe in pregnancy? The answer is yes. First-line anti-TB drugs are safe in pregnancy. So there are concerns regarding fluoroquinolone levofloxacin, but it is thought it is also safe in pregnancy when we treat tuberculosis. Right. So can these patients with tuberculosis, pregnant mothers, transmit TB to their baby? Yes, but it is rare. So maternal TB has a risk of vertical transmission. So this tuberculous basilemia during pregnancy may result in placental infection or female genital tract infection. So therefore, through the placenta and umbilical vein, the bacilli can transmit to the liver, causing primary complex in the liver, and also the infected amniotic fluid can be ingested or aspirated, causing the primary complex in the GI tract or within the lungs. So this is called congenital tuberculosis. And also after delivery, from mother to baby airborne infection can cause normal tuberculosis also. This is called neonatal tuberculosis. How do you diagnose congenital tuberculosis? So you have to have a high degree of suspicion. The main risk factor, the main point is mother having the active disease. The symptoms are non-specific and clinical signs are non-specific: respiratory distress, non-resolving pneumonia, hepatosplenomegaly, lymphadenopathy, abdominal distension, etc. The diagnosis of TB should be included in the differential diagnosis of chronic neonatal infection with a poor response to antimicrobial therapy. As the pointer to congenital tuberculosis is maternal infection, at the time of delivery we can send the placenta for histology and also for mycobacterial testing. Right, can we administer BCG for the baby? So at the time of delivery, if mother has untreated tuberculosis, we should postpone the BCG. And we should evaluate the baby for congenital tuberculosis, and if it is negative, we can start isoniazid prophylaxis treatment, that is tuberculosis preventive treatment. But the usual, the presentation is at around 3rd week of baby, therefore we should keep in mind regarding the development of congenital TB. So if baby does not develop congenital TB, we go ahead with isoniazid treatment, and at the end of 3rd month, we reassess with MAN2 test or interferon gamma release assay. If it is negative, we will go ahead with BCG. If it is positive, we will complete the treatment with isoniazid. And the last question is breastfeeding. Yes, it is safe. You should not avoid breastfeeding. Ask the mother to have a surgical mask and avoid coughing to the baby's face and breastfeed in a well-ventilated area. Right, thank you very much.
Thank you very much, Dr. Pull. I think for obstetric trainees, there should be a lot of new facts to be learned. So there are a lot of participants joining us through Zoom today. So before take the questions from the audience present here, let me take few questions from the Zoom participants. Dr. Daupadi, this question is for you. There is a question asking, can influenza cause lobar consolidation? What chest X-ray changes present, if any? Over to you, Daupadi.
Thank you very much for the question. Actually, lobar consolidations are less common in viral pneumonias, including influenza. Usually they get bilateral, like patchy infiltrates or opacities, or even the chest X-ray can be normal. Even the lung signs are present. If there is lobar consolidation, we should suspect, we have to suspect whether the patient has got coexisting bacterial pneumonias or we have to correlate with the blood investigations and have to send sputum cultures and all if the lobar consolidations are present, because it is quite less likely to have lobar consolidation along with the influenza.
Okay, thank you, Daupadi. And there's another question again to you regarding the dosing of the oseltamivir and how long we have to continue it. And also I have one question. Usually during the seasonal outbreaks, when we encounter these patients, sometimes we tend to start the treatments on a suspected basis without any confirmations or anything. So can we do it as outpatient setup, or if so, is it by a consultant's review, or is it for the general practitioners or family physicians? What do you recommend it for outpatient commencement of the treatment?
Okay, thank you for the question. And for the first question, sorry, I forgot. I have not included the dose in my slides. The dose is 75 milligram twice daily for 5 days. And for the second question, actually, the chemoprophylaxis. So, if the patient does not have any clinical features to suggest contact history or the symptoms I mentioned in the lecture. If in the absence of that, it's not recommended to start on antivirals. But if the patient has got the symptoms suggestive of influenza infection, then yes, I don't think it has to be started by a chest physician per se, but even the physician can start on antivirals, because sooner the better, rather than waiting to develop complications and all with regard to antivirals, because it is recommended throughout the pregnancy, even in the first trimester.
Okay, thank you, Dr. Daupadi. And there's another one question to Dr. Uppul regarding the same case that he has presented from the webinar audience. Can we safely exclude active TB in that pregnant lady? That was the question. And do we have to go for the lymph node biopsy, the continuation of that question?
Yes. We have safely excluded pulmonary tuberculosis here. Patient was asymptomatic, and the sputum microscopy was negative, and the gene expert more sensitive test is negative, and also the chest X-ray was normal. Even though we should wait for Mycobacterium tuberculosis culture, which we have taken. And regarding the lymph nodes, patient had actually, this was not the true picture of that patient. Patient had bilateral cervical adenopathies, and we did a scan. We did that showed bilateral adenopathies with preserved fatty hilum, which is one thing we are looking for in pathological nodes, whether the fatty hilum is absent or whether it is preserved. And then if we want to go ahead with the biopsy, we should offer general anesthesia. Surgeon was not happy to do under the local anesthesia, need general anesthesia. And therefore, at that time, we went ahead with FNAC, which showed again reactive nodes, and then we thought monitoring the patient whilst after starting the INH prophylaxis, because there is no absolute contraindication at that point to start isoniazid prophylaxis while waiting for further testing. So because patient is in our hand, so we are looking for, and we will do follow-up scan, and if there is if it is increasing in size, we will definitely offer the treatment or the further investigation with biopsy.
Okay, thank you. I think we can open the forum for questions from the audience. Any questions from the audience, please?
Now, regarding influenza and the other viral pneumonitis, I have two questions. So, first one is why this viral pneumonitis gets bad in pregnant patients? Whether there's immunity plays a role on that compared to the normal population that they get bad. Second question is the Tamiflu. There are evidence coming up for extended course of oseltamivir for critically ill patients who shed the virus for a long time. Now recommended is 5 days, but you can extend to 10 days. Any thoughts on that?
Yeah, thank you for the question. I have already discussed why these pregnant patients are more prone to get complications due to influenza because of their alterations during pregnancy in the immune system and the physiological other alterations in pregnancy. That's why they are more prone to get complications. And the extended dosing of oseltamivir beyond 5 days, it is in practice, but I have not, I have not seen, I couldn't find any studies about the extension of oseltamivir studies, but I will check it and I will try to let you know at the end of this discussion probably. Sorry for that.
Can I add to that? I'm Dr. Vatsala Gunasinghe, a consultant chest physician from Valisara. So one thing regarding influenza, we have discussed this over and over again, and national guideline is also there. Earlier we used to use this extended treatment, but the guideline, as I am aware, it's just recommends not the extended treatment. Earlier we used to extend for 10 days for ICU patients. Later on the evidence was reviewed, and this 5 days course is thought to be enough. Maybe there are newer evidence, I don't know, but that was the conclusion at that point. And regarding the TB case, I would like to say one thing, because one important thing you have to remember is when you are starting on latent TB treatment, always you have to monitor the patient, as you correctly said, Dr. Uppul said, monitor the patients, and always you have to monitor for the features of development of active TB disease later on. So that cannot be missed at any point.
Any other questions from the?
Yeah, this is regarding influenza again, because this is a practical question that I'm facing as a Carson Street Hospital physician. Now, when we treated for a mother with influenza A positive with Tamiflu, and the patient will going to develop basically the post-viral bronchitis for a period of time, and the patient is coughing and coughing. And again, my understanding is if the patient is had influenza A, the protection is only for influenza A. But in community, we are having the influenza B again. So if the mother presents in, I'll say about after 2 to 3 weeks with the same symptoms, are we going to repeat with the Tamiflu, or are we going to manage as a pneumonia or second week? Because we had 4 patients we treated with influenza, went home and came back with mycoplasma infection with a lobar pneumonia, right? And all 4 patients end up in the ICU. So my concern is for the second time also we are going to repeat with the Tamiflu in clinical grounds, or whether we are going to investigate further. My concern is again, because if I'm sending a sample to the MRI, it will take about 7 days. So I should not wait until without treating.
Yeah, first of all, thank you for that excellent question. I mean, viral pneumonias in influenza as well as in COVID, that we get this 2-hit hypothesis, where we get the first hit from the viral infection, usually the influenza, and then they get the second hit with the bacterial infection, usually strep, or it could be one of the atypical mycobacteria, or it could be, sometimes it could be hospital-acquired infection, depending on the hospital say. So I think the second hit, actually, you have to always consider, investigate, at the same time you have to treat, depending on the clinical suspicion for bacterial infections. But if you get influenza A previously, or if you had the vaccine before, you are not totally protected against influenza B, but you can get a partial protection against the other rest of the influenza viruses. So the damage caused by the virus itself would be less in the immediate second episode, but usually it is a second hit from a bacteria. Sometimes we see third hit with fungi as well. We have few patients now, we had a third hit with fungi. So the first hit virus, second hit bacteria, third hit fungus. So this can go on like that. But when there are multiple admissions, you have to think about more bacterial or more complicated infections rather than viral infections.
Okay, thank you very much. I think that is the end of our mini symposium regarding respiratory infection in pregnancy. So just to conclude, I'll just play a few of the summary slides. This is regarding influenza and pregnancy. Because the time is running short, we'll stick to the time. One of the main key important messages that we have to have a mandatory outpatient review in 72 hours, and it's a multidisciplinary approach with oseltamivir is the main drug of choice. And COVID-19 in pregnancy, it's mainly regarding the vaccination, which is proven safe during the preconceptional and the antepartum as well as postpartum period. VT was considered as extreme rare complications, but the benefits were far outweighed the risk. And then there was a wonderful discussion regarding the tuberculosis and pregnancy, and I think there are a lot of new things to be learned for the obstetric trainees from this lecture. So, and at last regarding the bacterial pneumonia and pregnancy. So, we have to consider the aspiration pneumonia as one of the main things during this peripartum period, as well as interpartum period due to gravid uterus, and we have to mainly focus on tachypnea as important symptoms, as well as the imagine there is no problem of going for chest X-ray, as we have to consider it as safe during pregnancy. So we'll conclude the session. Thank you very much for all the speakers who came from all along various places from country, Trinco, Gaul, and then Colombo as well as Puttlam. Thank you very much for committed for this and spend your valuable time. Thank you very much.
Thank you, sir. Another thought-provoking session clarifying controversies in managing respiratory infections in pregnancy. I thank the moderator and the expert panel for their valuable opinion. Now, let me cordially call upon Dr. Ananda Ranatunga, Honorary Past President, Sri Lanka College of Obstetricians and Gynecologists, and Dr. Chandina Bedametsri, Senior Obstetrician and Gynecologist from Teaching Hospital Kalutara, to distribute the tokens of appreciation and the certificates for the moderator and the panel of experts. Dr. Prabhat Randumage, moderator for the symposium. Dr. Daupadi Dharmasena, Dr. Amila Ratnapala, Dr. Geetal Pereira, and Dr. Upul Patirana. Thank you, sir. This concludes Symposium 2. With this, we'll be breaking for tea. Tea break is just for 15 minutes. And I'd like to remind that for the resource persons, tea will be served on the first floor. And for the delegates, the tea will be served at the canopies in the parking space.